Okay, well, welcome again. This is our webinar on patient treatment selection and disease monitoring by CTC enumeration. We have three distinguished speakers today. We have Shinyan Sandy Ao. Sandy is the director of multiplexing for Neogenomics, where she is responsible for the operational function of multiplexing modality, including multi-omics, vector Polaris, and RareCyte CTC technology platforms. She has over 15 years of experience in multiplex immunofluorescence assay development and validation in cell and tissue-based assays in support of exploratory, translational, and clinical research studies. Sandy also earned her PhD in biomedical sciences from the University of California at Riverside, and she also holds a master's degree in genetics from Fudan University. Our next speaker is Dr. Pashtun Kassi. And Dr. Kassi is Associate Professor of Internal Medicine, Hematology, Oncology, and Blood and Marrow Transplantation at the University of Iowa. Dr. Kassi's research interests are gastrointestinal cancers with a primary focus on colorectal cancers, precision medicine, and clinical trials. His research niche is around liquid biopsies, circulating tumor DNA, and circulating tumor cells. His residency was at the University of Pittsburgh Medical Center and fellowship at Mayo Clinic in Rochester. Additionally, he does hold a MBBS from Aga Khan University and a postdoctoral master's degree from the Mayo School of Graduate Medical Education in Clinical and Translational Sciences. And our third speaker is Wala Macaulay. Wala is a PhD graduate student in the pharmaceutics and drug delivery at the University of Iowa, working in Dr. Salen's lab and Dr. Kassi's lab.
All right, hello everyone. First of all, thanks a lot to RareCyte for hosting this event and invite me to present today. Great pleasure to have this opportunity to share with you our experience in implementing the RareCyte CTC workflow and use the technology for CTC enumeration. So the title of my talk is Configuring a Laboratory Workflow for Unbiased CTC Enumeration and Biomarker Research. So my name is Sandy. I'm from Neogenomics Laboratory. Here's the outline of my talk today. Before I dive into the technical part, I will start with some brief background about Neogenomics, who we are and what we do. And then I will then talk about the validation we have performed at Neo to implement CTC capability and how this fits into our overall portfolio for liquid biopsy testing. I will then also briefly touch the next step and future direction. Neogenomics is the leading oncology diagnostic and pharma service company. The business includes three major divisions to provide diagnostic and data solutions to serve oncologists, pathologists, pharmaceutical companies, and academic centers. The three divisions are the Clinical Service Division, Pharma Service Division, and the Informatics Division. The CTC service has been implemented in the Pharma Service Division. Neogenomics Pharma Service Division serves the pharmaceutical, biotech industry, and academic centers in support of research, translational, and global clinical trial studies. The headquarters of Neo is in Fort Myers, Florida, and has multiple sites across the United States. Neo has also grown the footprint globally and now has 3 international sites. Our European lab opened in 2017, located in Switzerland. We have the lab opened in Singapore in 2019, and this year we are working in our China lab that is in Suzhou. As pharma service, we offer a wide range of menu of over 650 tests, covering different technologies, including immunohistochemistry, multiplex immunofluorescence, flow cytometry, immunoassay, FISH, and a variety of molecular assays, such as nanostring, qPCR, and NGS. Our subject matter expertise offers end-to-end service from technical consultation, custom assay development, assay validation, to clinical testing for all the technologies. Liquid biopsy is increasingly used in cancer testing nowadays. It's a very attractive option, especially when tissue samples may be challenging or impractical to obtain. A family of validated liquid biopsy assays are offered at Neo as well that cover a broad range of important cancer biomarkers. A few options are listed in the table here. NeoLab solid tumor liquid biopsy assay is ctDNA NGS assay, validated and offered for clinical trial testing. Envision First Lung is validated clinical LDT assay, and the radar assay is a highly sensitive assay for MRD detection. To complement liquid biopsy offerings and expand our liquid biopsy capability to support clinical research studies, we onboarded the RareCyte platform for circulating tumor cell detection. This is the end-to-end CTC enumeration workflow. It includes the sample collection, cell transfer from tube to slice, staining, imaging, and analysis. This is a streamlined process from blood sample to results with minimum hands-on steps and can be easily scaled up. Now we can quickly go through each step in a bit more details. The process starts with sample collection. All it needs is a 7.25 ml blood in AccuCyte blood collection tube. The blood sample has up to 72 hours stability at room temperature. Once start of sample processing, the blood is transferred to AccuCyte separation tube and then separated into constituent layers by centrifugation process. After 2 centrifuge spins, the buffer coat with the nucleated cell layer is collected in the isolation tube. The last step to complete AccuCyte sample preparation is to spread the buffer coat onto the glass slice as single-layer nucleated cells. Up to 8 slices can be made from one sample. The slice can be processed immediately or be banked at -20 for up to 1 year before staining. The staining uses ReoPlex acid kit and is performed using the preset up staining protocol in the auto stainer. At Neo, we use LikeBond RX. The stain slides are then scanned on SiteFinder 2 with the preset scan parameters. All the target CTCs are identified and ranked by the machine learning algorithm. The trained analysts can then review and confirm if these are the target cells. A final report can be then generated for each sample when the review is completed. Here's one of the representative staining from the enumeration assay using spiking sample. The assay includes staining for nucleus, CK-EpCAM, and CD45. The imaging acquisition is done for the whole slide. Each orange box here includes the target cells identified as CTC by the algorithm. Analysts has option to preview the panels of these images and then review the biomarker staining for each individual cell. The CTCs are defined as nucleated cells that express CK-EpCAM but negative for CD45. The reviewer can go through each cell and confirm if this is the target phenotype. To onboard the CTC enumeration assay, we performed Reo Validation. The first part was the AccuCyte user certification process RareCyte offers to demonstrate the proficiency in use of the AccuCyte sample preparation system by the user. Spiking blood samples with around 800 CTC were used. Each analyst at Neogenomics processed 2 samples, and 2 samples from the same batch were processed by RareCyte. The assessment is based on if new user results are within the acceptance range defined by 95% confidence interval of RareCyte results. The acceptance range for this certificate run was roughly around 600 to 1200 cells, and the results from the new user were actually all fell into this range, roughly between 700 to 1,000, so which really indicated that all the new users passed the certification. As part of validation, we evaluate the assay repeatability. For this evaluation, we use spiking samples with expected 100 CTC cells per slide. The repeatability was assessed using 5 replicates in 3 runs. The predefined successful criteria is less than 20% CV. The percent CV was calculated in each run as summarized in the table. The data for each run showed a range of CV between 8% to 12%. All the runs were able to meet this successful criteria. Reproducibility was also assessed in the validation along with linearity. The study includes triplicate sample at 3 CTC concentrations. The 3 concentrations were serial of 1:3 dilution. The expected ratio for these samples should be 300 to 100 to 30. We evaluate the percentage CV for different dilution. The percent CV was less than 20% for dilution 1 and dilution 2, 8.5% and 18.6% respectively, and one a bit over 20% for dilution 3. So this dilution was just about 30 CTC per sample, which really translated to 4 cells per slide. So the CV was still considered very tight. So the repeatability and the reproducibility data together demonstrates highly consistent performance of the assay. We evaluate the linearity in this study as well, and show coefficient R squared was above 0.99, demonstrating great linear performance. So what's important here is really the 3 dilutions demonstrate the range usually obtained in the clinical samples. And this set of data really demonstrates its reliable CTC enumeration performance across the range that is usually present in the clinical samples. So as a summary, the validation was able to meet all the predefined successor criteria, including user certification, precision, and the linearity. The precision data demonstrate highly consistent performance of the assay, and the linearity indicates reliable CTC detection across a range present in the clinical sample. Limit of blank was also evaluated in this Reo validation. The data wasn't included in here, but the 3 samples with different healthy donors were all evaluated and will all show the negative results as expected. During the onboarding process, we worked very collaboratively with the RareCyte team, and the team is very helpful in supporting for all the steps, including installation, qualification, and the training. With this validation, we can now offer enumeration assay for unbiased, reliable CTC detection to support clinical research study and Neogenomics. As our next step, we also plan for multi-site deployment for enumeration assay. We're in preparation to certify additional international sites for AccuCyte sample processing, and this way we can bring in the capability for us to support global clinical trial. We're also proceeding with bringing more RareCyte panel kits with biomarker detection. For example, the ARV7 panel kit for prostate cancer. The other capability we are planning to implement is the integrated approach to enable imaging and molecular analysis. This process includes single cell retrieval by site picker and then use it for downstream molecular application. This could really leverage the expertise we already have at Neo, and will be great add-on to our liquid biopsy offerings. And we look forward to continuous collaboration with RareCyte team for the implementation. To close my presentation today, I really want to thank my colleagues at Neo for their hard work on onboarding the assay and the technology. Many thanks to the RareCyte team for all the help and support. And thank you for your time today. And now I'm going to turn this to our next speaker.
Hi, thank you for the opportunity. I'm an associate professor at the College of Medicine, and while as our PhD student, my email as well as our Twitter handle is listed there. Would love to continue some of the discussions online after the webinar as well. These are my disclosures in terms of consultancy and advisory board from industry. Also, we will be talking about off-label use of liquid biopsies, ctDNA, CTCs here. Essentially, what we wanted to do today was, you've already heard about the platform and the methods. We wanted to see if it would be feasible in patients with GI malignancies. So it was more of a discovery effort with lack of data with respect to GI cancers about CTCs in general, not just about this platform. We wanted to see, is it feasible, not feasible? What kind of results do we get? Plus, as we know, there are a lot of pre-analytical variables and clinical variables and tumor variables that can come into play. And today we're going to give you a snapshot of our first set of analyses of what we have found so far. A brief background on GI malignancies, as well as what's in place in clinic right now, which is revolving around circulating tumor DNA. Right now, a lot of the commercially available NGS platforms offer the ability to quantify ctDNA, but then also they can report on the plasma MSI status. So right now, for advanced or metastatic cancer patients, this is something that's FDA approved, readily available and orderable across different platforms. And broadly speaking, right now, there are two different platforms. This is our editorial in ASCO Daily News from last year, if you get a chance to read. Essentially, it divides the platforms into what we call tumor-informed platforms, where you need a piece of tissue initially to come up with a custom panel. And then there's a tumor-agnostic platform, which is does not require tissue, so it's plasma only. So these are available right now in clinic to be ordered, not just from acquired resistance treatment response, but there are assays now that are going into the MRD space. As Sandy mentioned, there's one from Neogenomics as well, and also going into early detection and diagnosis as well. In terms of just the background, a lot of this applies to CTCs as well. This is an ASCO combined paper with the College of American Pathologists, worthwhile looking at all the variables and things in publications pertaining to liquid biopsies in general and ctDNA in particular. And this is from March of 2018, where they had concluded pretty much that maybe a lot of this was not ready for prime time. However, every year now, this is just from, if you type in the word ctDNA or liquid biopsies, there are hundreds of abstracts looking at concordance, serial monitoring, resistance. So again, these are not my slides. Some of these slides are from discussants from some of our major oncology meetings. And as you can see, these are the same discussants after the consensus statement came out. A lot of this is ready for prime time. More recently, published in Nature, this is the NCI task force statement. Again, looking at variables from which tube to collect, when to collect, how to process the volume. Again, a lot of this pertains to ctDNA because that's what's available in clinic right now. But a lot of this applies to what we would be talking about, CTCs in general. And as you can see, a lot of issues that pertain to limitations in early stage cancer do not apply to metastatic disease. And that's something that we found in our cohort of GI malignancies as well. Now, just to give a broad sense of what's happening in the world of GI cancers, because not everybody in the audience here is a clinician, one important thing that you might have heard already across different news channels and media outlets is more young people are dying of colon cancer. And right now, the average age of screening was 50, it was moved to 45 for the very same reason. Individuals who are in their 20s, 30s, and 40s are getting diagnosed with colon cancer, and we don't know the reason why. And even right now, within colorectal cancer too, even though we think of this as a long piece of tubing, cancers that originate on the right side of the patient are different than the cancers that originate from the left side. So there's a lot of what we call spatial heterogeneity, even within colon cancers. And with the rise happening in the age less than 50, so what's happening is some of these patients are alive for years on treatment. This is just a snapshot of the different tools in our toolbox. As you can see, there are a number of chemotherapy options, targeted therapy options, immunotherapy, fusion inhibitors, refractory salvage drugs. And what that basically means is survival, which was in the order of months. Right now, this slide is a decade old. A lot of our patients with stage 4 incurable metastatic colon cancer are living in the order of 3-4+ years on average, which means that the cancer over time, and that happens all the time for our patients, they do respond to treatment, but at some point in time, they stop responding. And molecularly, there are probably resistant clones that are developing, and things like liquid biopsies, whether they are ctDNA platforms, and here as we talk about CTCs, you can capture these clones and see what's resistant and what's different about them. So it's not the same cancer. So not only is there heterogeneity at baseline, there is also temporal heterogeneity that happens from a selective pressure of treatments and acquired resistance mechanisms. Segue to a different cancers, just to give you an idea, there are cancers which are called cholangiocarcinoma, which are bile duct cancers. These are the drainage or plumbing from the liver draining bile, and including the pancreas here in the background. These are cancers where diagnosis is particularly difficult because biopsy is usually done through an endoscope and the needles are small. So let alone getting enough tissue for diagnosis, it is often the case where we don't have tissue for sequencing because it's a very target-rich disease, and if you don't have enough tissue to be able to complete that, you cannot prescribe these particular targeted therapies, and some of them just got approved within the last year. Here is one other place where liquid biopsies in general for GI cancers are of particular value, because if more than half the time you don't have enough tissue, you could just get away with a plasma sample, or in this case, a CTC sample for analysis. And that's what already is happening in the clinic, not something that is distant from the future. What we wanted to set the stage was, while we do a lot of circulating tumor DNA assay platforms as part of our standard of care in clinics, some of them are FDA approved, some of them are through expanded access programs. As we know, ctDNA is not the only way, or not the only test that falls under the broad umbrella of liquid biopsies. Obviously, there are a lot of other assays, exosomes and RNA and other platforms that are being developed. But the other thing that we were particularly interested from a GI malignancy standpoint were circulating tumor cells, which is the topic of today's discussion. The reason why this would be important to kind of fill the void, again, this question is not to replace ctDNA platforms, but there are aspects in terms of immunohistochemistry, protein expression, single-sense sequencing, that CTCs can fill the void that ctDNA platforms don't offer at present, and vice versa. And a lot of the work for ctDNA, while that has been going on for years, CTC, at least in the clinic, is something that's very recent. A lot of the work has been revolving around prostate and breast cancer platforms, and there was limited data at the time we started our endeavor in collaboration with RareCyte regarding the use of CTC in GI malignancies. What we started to focus on was multiple sample collections for the same patient, so we could also study kinetics in response to treatment or progression, meaning that the cancer is worse. We also, again, I won't go into the methods part, which was already described, but there are multiple benefits of using the current platform as opposed to some of the other size-based enrichment methods or immune-based enrichment methods. And we chose RareCyte as the preferred platform for multiple reasons highlighted here. This was already discussed in terms of the workflow by Sandy, but from a clinical practical perspective, this was very helpful for us because the turnaround where the sample could be still processed within 72 hours was helpful because, here we are seeing patients at the University of Iowa, shipping them and still being able to meaningfully do the analysis within time, pretty much any day of the week, was a huge advantage and a win-win for us to choose this platform. Now, within the platform, as Sandy mentioned, there are an option of a la carte options in terms of what other biomarkers to choose. Since our focus was gastrointestinal cancers like colorectal cancers, pancreas cancer, neuroendocrine cancers, we wanted to select from the current list of available panels things that would be relevant from a GI perspective. So in addition to the typical nuclear stains, CD45, EpCAM that's meant for CTC enumeration and identification, we selected HER2, PDL1. A third of the gastrointestinal upper GI cancers are HER2 positive. Colorectal cancers are HER2 positive. Bile duct cancers are HER2 positive. PDL1 goes without saying, is an agnostic marker across many platforms or tumors requiring immunotherapy. EGFR with anti-EGFR therapies, as well as resistance mechanisms, was a marker of interest. And obviously proliferative markers like Ki67 or Ki67 were things that we chose. And going back to how Sandy mentioned that, with each sample you could get 8 slides, we had developed a workflow where we would do the enumeration first and automatically reflex to markers if we identified CTCs on the initial slide. So we didn't necessarily waste all the slides. And as mentioned, this could be biobanked and stained later, which is another strength that attracted us to use this platform. So we'll start with the results. Again, this wasn't necessarily a clinical trial or a systematically designed process. This was more of a discovery platform, and but we still were able to find very intriguing results, and Walla and I will go over them.
Yeah, so in our study, we have so far 59 patients. For most of the patients, we were able to collect 4 blood samples at 4 different time points. So in total, we have around 200 samples. The table below show the baseline features for our patients, their age, median, and mean, the number of female individuals versus male individuals, in addition to the number of patients who were on treatment before collecting their blood samples and patients who were not on treatment. And to the figure, in the figure to the right, these are the criteria for detecting the circulating tumor cells. The circulating tumor cells were positive to CK and EpCAM stain, and also they show a positive to the nucleus stain, and on the other hand, they were CD45 negative.
And as you can see, we saw a broad variation, like not just CTCs here. You can see there were clusters. So some of the quantification we wanted to be conservative is probably an underestimate. There were situations where there were clusters that probably had dozens of CTCs in one snapshot. As here they're sharp apart, but there were situations where there were tons of CTCs depending on the particular tumor type and when during their treatment journey was the sample collected. So the strength, as you can see, we had almost 200 samples, plus each patient acted as their own control, since we were able to get at least 4 time points depending on when they were coming back for their treatment visits.
Our study included patients with different cancer types. 54% of the patients were colorectal cancer patients, and the rest of the patients were esophageal gastric, pancreatic cancer patients, cholangiocarcinoma, and in addition, we have a few patients with other types of cancer.
And this is pretty much representative of what are the common cancers. So again, we didn't necessarily select which ones we were going to consent for the study or not. So anybody with advanced or metastatic cancer, ideally, as we learned along the process that we'll show you, we wanted to at least get the baseline sample before any treatment began, and when there was a treatment being changed, and ideally if they were doing their treatment at the University of Iowa, so that we were able to get serial sampling as indicated earlier.
In this graph, we were trying to look at the frequency of detecting circulating tumor cells. We can see from the graph that the frequency of detecting CTCs is decreasing by the increase of the number of the CTCs in a blood sample. And this indicates how much it's rare to find circulating tumor cells in blood samples of cancer patients. But at the same time, it indicates that even detecting very low number of circulating tumor cells can tell something about the progression of the disease in the patient.
And also, from an assay standpoint, as Sandy showed some of the analyses earlier, it's not just the assay that's here in question. You have to understand the clinical context, the timing, and that's what we learned during the discovery platform, that there were patients with dozens of CTCs, and there were time points in the same patient where we didn't detect CTCs, and we'll show you how some of these treatment variables and tumor types can make a difference. So in addition to the particular assay, it's important to understand the dynamics of what's happening with the patient in the clinic, which can impact the collection and the results. Also, just as a side note, what you see on each slide moving forward in terms of CTCs, these are actual CTCs from several of our patients, just to kind of give you a visual of the different shapes and sizes and clusters that we saw across our tumor types. One thing I wanted to kind of mention was, in addition to ctDNA, and there's less data for CTC, but it's evolving, it has a very short half-life. So if you start somebody on very effective therapy, within a couple of weeks, you see ctDNA going down almost 90%. So keeping in mind, the blood draw, especially if you're looking at baseline evaluation, you ideally want it before the treatment begins. That's very true for ctDNA. No matter how sensitive the assay, if you draw it several days later, the half-life of ctDNA is in the order of hours to days. And again, some of our initial work here, we think that CTCs even have a shorter half-life if you start somebody on effective therapy. So it would be an important hypothesis generating early, probably one of the earliest dynamic markers of response to treatment.
In this test, we were trying to compare between the mean number of CTCs in a group of patients who were on treatment versus the mean number of CTCs for patients who were not on treatment. Interestingly, we found that the mean number of CTCs in the group with no treatment is significantly higher than that in the group with the treatment.
So again, goes without saying, effective therapy can clear CTCs, ctDNA very rapidly. So while you may find dozens if somebody was not on treatment versus going down to almost a median of 0 if an effective therapy began. So this particular variable is a person on treatment versus no treatment can be critical no matter how sensitive the assay is.
Also in here, we compared between the mean number of CTCs in different group of patients based on their response to the treatment. So we categorize the patients depending on the response to the treatment. We have the baseline group. It was for the patient who we collect their blood samples before starting the treatment. We have the progression group for the patient who didn't respond to the treatment, the response group for the patient who responded to the treatment, and the stable disease group. It's the group of patients who they show stable tumor during the course of the treatment. Interestingly, we found that the mean number of circulating tumor cells in the response and the stable disease were significantly lower than the mean number of CTCs detected in the baseline group.
Again, within treatment as well, as Walla mentioned here, it's not just is the person on treatment, is the treatment working or not, and especially as you can see at progression. So at least from a detection of CTC standpoint, if you were to pick and choose which time points you would want the assay to be performed, both from a cost as well as efficiency perspective, if it's not the baseline sample, ideally it should then be the progression sample. Now, obviously, if you had a baseline sample, lack of detection of CTCs is an important variable. There are multiple studies, both progression-free survival, overall survival. If you didn't detect CTCs, while it's not a great lab result because you can't process anything further, but from a clinician and a patient standpoint, lack of detection of CTCs is indicative of the person is responding to treatment, which means that in the long run, that's the ideal scenario. And that's true for ctDNA and also some of the early CTC results as well.
In this figure, we can see the difference in circulating tumor cells detected based on the cancer types. So we can see colorectal cancer patients in general have the highest mean and median number comparing to other cancer types. So as we can see from the figure, colorectal cancer patient has the highest mean number of circulating tumor cells. On the other hand, pancreas cancer patient has really low the number of CTCs comparing to the colorectal cancer patients.
Now, while we didn't have any baseline information, this makes good clinical sense for those of us who treat pancreas cancer. There's a lot of dense fibrosis. There's a lot of dense tissue. And that's true for ctDNA detection as well. Pancreas cancer, the same assays that detect or report 80, 90+% sensitivity, their sensitivity goes down to almost 50, 60%. So we, on our weekly analysis calls with our colleagues at RareCyte, even if a sample wasn't labeled, if we saw dozens of CTCs at baseline in a patient, we could already pretty safely assume that that patient had colorectal cancer. And again, all these analyses were blinded, so our RareCyte colleagues didn't know which sample, which time point were these being sent. But you can clearly see some of the demarcation based on tissue type. And some of the studies even show that, as I was showing you in the cartoon earlier, even the right versus left-sided cancers can make a difference. So not surprisingly, tissue types also made a difference.
Also in here, we can see the difference in mean number of circulating tumor cells based on the cancer type. But in this case, we looked only at the baseline group, the group who were not on treatment before collecting their blood sample. And again, we can see colorectal cancer patients have high mean and median number of circulating tumor cells comparing to the other types of cancers. In this graph, we are showing the percent of patients of each cancer type that had a CTC count higher than each of the cutoff values used in the graph. Our cutoff values were at least 1 CTC and at least 3 CTCs. As we can see, at least 1 CTC was detected in 50% to 71% of patients of all cancer types, and at least 3 CTCs were detected in 26 to 30% of patients.
Now, again, these are arbitrary cutoffs that we chose because there are papers and publications using these cutoffs so that we could draw a comparison. Also, as well, I would show on the next slide, we also took cutoffs of 10 and 20 CTCs just to see and demarcate if we see a pattern.
Yeah, as Dr. Cassie mentioned, in here we used another cutoff values, which are at least 10 CTCs and at least 20 CTCs. Interestingly, if we look at the at least 20 CTCs, colorectal cancer patient have 11.4% of the patients show at least 20 CTCs, comparing, for example, to pancreas and cholangiocarcinoma patients with 0% patients with CTCs more than 20 CTCs.
And this number, just for clarification, these are the percentage samples. So obviously, some of these patients were on treatment. So if you truly looked at baseline samples, nearly every single time colorectal cancers had dozens of CTCs, whereas pancreas cancer patients, usually it was like single digits. So the actual number is lower because other than the baseline time point, other 3 time points were on treatment, which affects the CTC clearance. And again, our observations are not just, these are multiple publications. As you can see here, colorectal cancer is kind of on a poster child for a lot of these liquid biopsies. So within GI cancers, if one to focus where you have a good yield, again, the assay would work better if you have good substrate. Here, colorectal cancers have the highest shedding, so to speak. And as you can see, pancreas is almost right next to like brain tumors. So you see minimal shedding, which is something that we observed as well. So even though, you know, again, we have a heterogeneous sample size of about 60 patients with 200 samples. So not necessarily a small endeavor, but at the same time, you can see patterns similar to what's been reported out before is observed. This is one publication. This is another one. Again, colorectal cancer is the highest in terms of shedding. This is shedding of ctDNA. We saw similar patterns in CTCs as well. And again, for the ones where we truly were able to select baseline samples, here are kinetics.
Yeah, so in here, we looked at the change in circulating tumor cells in some patients. For example, in the graph, we have an esophageal gastric cancer patient who started with a crazy number of cells. It was around 115. And then the CTCs dropped to about 0 within 2 weeks. And we can see the same trend for the other 2 patients who they were colorectal cancer patients.
So as you can see, within like a couple of weeks, again, these were practical arbitrary cutoffs because most of our treatments in GI cancers are every 2 weeks. So this was convenient sampling. So unless somebody was here for a lab check or this, we piggyback the sample collection. So while you can see here, you're detecting anywhere from 30 to 100 plus CTCs before you began treatment. If you were to order the same assay later on, again, while it's helpful from a patient standpoint that the person is clearing the CTCs, you would miss the broader picture if you didn't collect the baseline before the treatment evaluation.
Yeah, also same trend was noticed in another 2 patients. The patient with about 23 CTCs is a colorectal cancer patient, and the other one is a pancreas cancer patient. Again, we notice the trend, how the CTCs dropped within 2 weeks. And interestingly, in this figure also, we noticed that the number of CTCs detected for colorectal cancer patient, usually it's higher than that for a pancreas cancer patients.
Again, this picture, like Walla mentioned, nicely summarizes the patterns that we were seeing, baseline, single digits. So this patient had pretty much same, if not more, cancer spread out throughout the body, unfortunately, at baseline with pancreas cancer, but yet the number of CTCs were single digits, 3, 4, 5, versus a colorectal cancer patient, similar tumor volume, dozens of CTCs as high as 60, 80 in some other cases. This is just one example of the same patient. As you can see, there's tons of cancer. And this is in response to treatment. So not surprisingly, you see the CTCs go down as early as within a week of treatment. In the same patient, we were able to look at ctDNA and tumor marker trends, and the CTCs cleared the first. Obviously, imaging is something that we do at 2 to 3 months from time. So in addition to enumeration, serial enumeration holds promise from being an early marker of response to treatment, in addition to what's known about ctDNA that's already out there as illustrated in this graph. So in summary, in future direction, we were able to not only show the feasibility of being able to detect CTCs across different tumor types, we were also able to nicely show that there are patient, tumor, as well as treatment variables that have to be taken into context as you interpret any of these results. And ideally, the baseline sample is what is critical here, but as long as you have the baseline sample, putting the clinical context on the serial evaluation gives you that perspective too. We haven't presented results on the markers here, but this here, for example, shows that we were able to reflex to EGFR, Ki67, PD-L1, HER2 staining, and we were able to show tumor heterogeneity across these samples as well. We know these clones evolve over time. This is just an example of one targeted therapy in colorectal cancer where new clones can develop. And if you're able to do single cell sequencing, you can check if there are resistant clones that are being developed or not. And for the ones that we were able to identify CTCs in, we were able to do a CTC NGS platform, again, with collaboration with RareCyte, where, as you can see, the clonal APC gene mutation is seen both in tissue, ctDNA, as well as CTC NGS. And again, one thing that we didn't mention here is the plasma, since it's not utilized, can also be biobanked for reflexing for ctDNA analysis. With this, we'll stop here and would love to get feedback and comments and questions. While questions are being popular, I just wanted to acknowledge that all this funding was with our University of Iowa Center of Advancement, which is primarily patient and caregivers and philanthropists who have donated. We are really appreciative of their trust and support for this huge endeavor, which, as you can imagine, took a lot of time, effort, and resources. I can see there is a message, a question about can we detect CTCs in stage 1 and 2 cancers? The short answer is yes. There are some publications looking at CTC collection in colorectal cancer, and the number of CTCs do increase, not surprisingly, as the stage increases. However, as mentioned earlier, with limited resources and lack of much data, we wanted to focus on where we would know there should be CTCs present, i.e. those stage 4 cancer patients. Also, just like I mentioned earlier, there are things that CTCs can do that ctDNA cannot, and there are things that ctDNA can do and CTCs cannot. And even within ctDNA, for example, if you're asking about a stage 1, 2 cancer patient and looking at something called minimal residual disease or molecular residual disease, which means that whatever is left behind after the curative intent surgery, for those, I would say, ctDNA or methylated markers would be things that you would be able to detect, because it doesn't include just the CTCs that were able to make it into circulation, but also includes any shed over DNA that comes from organs and stuff. So CTCs here, I would see the value in more advanced setting with spatial as well as temporal heterogeneity. There's a lot of interest in target therapies and clones evolving over time. So I see the role in more stage 3, 4 situations. But yes, stage 1, 2, you can detect CTCs, but their numbers are lower. So a negative doesn't mean that you don't have cancer. A positive is very specific.
I actually have another question. Dr. Kasi and Walla, this is probably for you. Did CTC clusters correlate with disease states?
So it did correlate with disease state, and also it correlated with the disease burden. In patients, like for example, as illustrated in the image here, unfortunately, a lot of these cancers, as an oncologist in clinic, they get diagnosed by the time it's already spread. So here, this is an illustrative image of a PET scan of a patient where you can see the primary tumor arose right here in the transverse colon, and then it spread to the adjacent lymph nodes, and then it spread to the liver. As you can see, this is the liver. It should not have any dark shadows in it. Here you can see the entire liver being replaced with metastases. This is in response to treatment. You can still see, a shadow there, but most of it is melted away in response to treatment, shown here by the golden image here, and pre and post treatment. So a patient like this, our observation was, we not only were able to find dozens of CTCs, we also found clusters in them too. The other thing that we didn't mention is, while CTCs cleared pretty quickly, if you dug in a little bit more detail, patients like this who had dozens of CTCs, we were able to find apoptotic bodies, especially within the first week or two of the draw. So while, again, by the FDA definition, they didn't meet criteria for staining, knowing what was there before, we were able to identify apoptotic bodies early on, and they subsequently cleared up as well on effective therapy, like shown here in this patient.
Wonderful, thank you. It looks like we have another question. I noticed that the CTC sizes vary greatly. Did you notice any correlation of CTC size with state or disease type?
That's a great question, and that's why I think going back to this particular platform versus some of the microfluidic technology where you can separate CTCs by sizes, not just across different tumor types, even within tumor types in the same patient, we saw a very wide variation. Like even this, for example, this is the actual CTCs that we found. You can see wide variation even within the same patient. So here, since it's not enriching by any methods or size, it's separating out CTCs. You're not going to miss any CTCs of interest. Now, we didn't dig deeper into comparing CTC sizes. That wasn't the goal of this project, and I think it's beyond the scope of what we could do, but it does vary with tumor types. It's already been described. It does vary within patient as well, and that's where we wanted to be mindful of this as a platform where size is not going to be a variable that will filter out cells of interest.
Wonderful, thank you. And another one we have, should you usually run 3 slides to get an average CTC number?
So that's a great question. Again, arbitrarily here with the one vial, we were able to collect or make 8 slides. So our default workflow process was that we were staining 4 for the enumeration and reflexing 4 for the biomarker. And then they've been normalized to the sample, which is the 8 slides. Now, for many of these patients, we, as part of our IRB approved project, we had 2 tubes collected. We wanted to, like I said, take all the pre-analytical variables out of the equation. So we did 2 blood collections and then normalized it to 1 tube just for the sake of comparison. And that's why you'll see decimal points. But I think it's, you can normalize it to whatever you think is going to be your workflow. For us, it was an even number. So we went with 8 slides. And in situations like pancreas cancer, where CTCs were hard to find, we actually defaulted to saying that we're going to use all the slides no matter what, because there were instances where if you only looked at 4 slides, you may say no CTCs found. Lo and behold, look at 4 or more, you found 3 on the remainder 4 slides. So I think the actual size and number, the actual number of slides you want to analyze will be tumor dependent, where you would want to increase the denominator to higher number in instances like pancreas cancer, where the CTCs are low, or even during treatment where you expect that the CTC count may be low. So you want to keep the denominator consistently across, but I think it's variable depending on which question you are asking.
Another one on CTCs. Did the extra biomarkers you tested on CTCs correlate with tissue biopsies?
So for the select ones where we had information, for example, for patients that were for HER2 positive who were getting HER2 therapies and were responding to treatment, yes, we were able to show those. Some of these markers, like some of these patients who had very high Ki67 with dozens of CTCs, like Waller presented earlier, like this particular patient which had the highest number of clusters at baseline with hundreds of CTCs. This patient's Ki67 on tissue was nearly 100%, and on liquid 2 we found it nearly 100%, but some of these, remember, haven't been validated. So we did see heterogeneity where often, the PD-L1 expression or HER2 expression was 50% of the cells, not all the cells. And that's not surprising. There is spatial heterogeneity even within the same patient, and that's where I think you have the option of looking at these cells separately, both immunohistochemistry through immunohistochemistry as well as NGS testing.
Thank you. And looks like one more. Could you summarize the key reasons you chose this platform?
So the key reasons, one was we didn't know that looking at the size-based platform, we didn't know if that would alone be sufficient, and we didn't want to miss, especially any cells, if we didn't know what to look for. Secondly, we wanted to have a workaround. Again, I'm a clinician, that's my first job. My physician scientist hat is my second job. So we wanted to get CTCs into clinic. As illustrated earlier, while there are many applications of CTCs, ctDNA in the clinic, CTCs are not yet in clinic. So we wanted to be able to work with a platform that I could send off a specimen and get real-time results without having to figure out a validation platform at my institution. So this platform and results, any physician in anywhere in the country can send off. There is a sample. So all we did, we wanted to be in a situation where, not knowing what other variables could affect CTC collection, we wanted to have collaborate with a platform where, number one, we could get real-time results. Number two, we could get reliability in terms of getting the results back within any day of the week. So even if I saw a patient on Friday, I knew the specimen could be shipped and be there with RareCyte on Monday or Tuesday and analyzed, the results being available. So we wanted to take the clinical factor out of the equation and resources at your own institution out of the equation. So all you need as a clinician in my shoes is to be able to send a self-addressed FedEx envelope off to RareCyte. We didn't have to reinvent the wheel. Also, during the COVID-19 pandemic, it was extremely important because a lot of the research endeavors had to be on a hold since a lot of the labs were shut down. So if there was any process on RareCyte's end that had to be done on site here, we wouldn't have been able to do all of this. All of this work was during the pandemic. So if any of this process required me or Walla to process anything at our lab, well, too bad. Unfortunately, we wouldn't have been able to do it. With this flexibility, in addition to all the technical factors that were outlined earlier by Sandy, we chose RareCyte as the preferred platform so that it's consistent, reproducible, and also if I wanted to collaborate with my colleagues at other academic institutions, we all are getting the same reliable results. And looking at integration into clinical trial platforms, we also wanted to partner with a platform where none of those barriers are at play as long as we can get the sample to the company in real time.
Wonderful, thank you. And we have time for one more question, which is, when using Site Picker, will you also get some non-cancer cells?
Theoretically, that's possible. However, in terms of, we did do NGS testing on some of these cells. So these cells did harbor the clonal mutation. So, and also going by the FDA definition of multiple stains, looking at not just the nucleus, but the epithelial markers, I would imagine that it would be hard to have an epithelial marker in circulation unless it's from the cancer. So while yes, theoretically that's possible, but I think with the multiplicity of the channels that are selected, including whatever biomarkers of interest, as well as RNA testing, I think it would be rare that were to contaminate the sample.
Thank you. Well, this does conclude our webinar. So thank you to our speakers and thank you to everyone joining today. And we look forward to seeing you on our December 2nd webinar.